So now, we've talked about all the good things that these drugs do. Now it's my job to talk about some of the bad stuff that drugs can do and why we need to be aware of them. So just to give you some background, drug-induced liver injury, first of all, it's the #1 cause why drugs die in the development pipeline. It's the leading reason why drug development is stopped. And it's a huge component of why it takes $1.4 billion to bring a drug to market, because we still don't have good ways of early assessment of liver injury from drugs. And many drugs go a long ways through development before we discover drug toxicity. So drug-induced liver injury is an injurious and unintended effect of a drug on the liver. Operationally, we define this by an elevation of AST and or ALT. Remember the liver injury markers we talked about this morning? More than 3 times the upper limit of normal, if previously normal, and an elevation more than 5 times the upper limit of normal, if abnormal when the drugs were started. So if somebody has some chronic liver injury or chronic liver disease before you start a drug, or they have any other reason for their liver enzymes to be slightly elevated, then somewhat different threshold. Or you can get if you get a cholestatic injury, the alkaline phosphatase should be 2 times the upper limit of normal. And one may see, depending on the severity of the injury, an abnormality in liver function, which would be either a rise in bilirubin or INR. Now, because these are usually acute events, albumin is not in the mix, because albumin takes several weeks, because the half-life of albumin is 2 to 3 weeks. So albumin takes a long time. If the albumin is down, it either means there's more going on chronically, or this drug injury has been going on for a while. If we look at the causes of drug-induced liver injury in the United States, the leading cause of drug-induced liver injury are antimicrobials. We can see, in addition to the antimicrobials, occasionally dilantin toxicity. Most of this is dilantin, a little bit from valproate. And then there are some oddball things. Statins is down here. We talk a lot about statins, but statins really contribute to a minority of drug-induced liver injury. So the bulk of this is in this green part of this pie, and these are antimicrobials. It's almost half. And there are 4 antimicrobials that essentially contribute the bulk of this. And these include augmentin, nitrofurantoin, which is widely used, and then Bactrim, and to a lesser degree, INH, just in terms of absolute burden of drug-induced, to the total burden of drug-induced liver injury. If you look at the distribution of severity of drug-induced liver injury, roughly about 30% are relatively mild, and then a little bit falls in around 20%. So 50% are mild to moderate, which means 50% actually are moderate but significant enough to put people in the hospital, and then you have the severe, and there's actually about 8-9% actually end up dying from drug-induced liver injury or needing a liver transplant to save their life. So there are 2 types of drug-induced liver injury. Type A is a dose-dependent, very predictable injury. So it is a common where the reactions are expected exaggerations of a drug's known pharmacological effects. So the more you give, the more of the effect that you will get. It is predictable, and it is preventable. And these occur either by overdosing deliberately, or altered drug metabolism, or due to increased sensitivity to the drug's normal pharmacological effects. So Tylenol toxicity, which is the leading cause of drug-induced liver injury and drug-induced liver death, or actually drug-induced death, in the United States. That's a classic textbook dose-dependent drug-induced liver injury. The second type is more vexing. It's called idiosyncratic. It is unrelated to the pharmacological action, so it's unpredictable. It's not part of the normal spectrum of what the drug is supposed to do, and is uncommon and can be quite rare. So the incidence may be 1 in 10,000, 1 in 20,000. So you're not going to pick it up in your routine clinical trials. And frequently these are discovered only after a drug hits the market and there are 200,000 or 400,000 people taking a drug. And so these are rare, but potentially are often more serious than type A reactions, frequently because they're not recognized, because these are so rare, it's not what people think as soon as somebody has a liver injury that, oh my God, this drug could be causing this. So you got to have a really low threshold of suspicion for thinking about this. In terms of the type of injury that drugs produce in the liver, you have the full spectrum of injury. So you can get massive hepatitis. This is parenchymal injury, where your AST, ALT would be the main thing elevated. You can get pure cholestasis. You can get cholestatic hepatitis, where you get both hepatitis, which is your liver cells are killed, but you also get cholestasis. You can get chronic hepatitis with or without massive necrosis. We're now increasingly recognizing that you can develop fatty liver and actually steatohepatitis from drugs. So there is a whole class of drugs such as amiodarone and diltiazem and tamoxifen, which produce fatty liver and can actually lead to cirrhosis. So a lot of the new drugs that are being developed to reduce lipids, especially the drugs that prevent triglycerides from getting out of the liver, lead to triglyceride accumulation in the liver and causing fatty liver disease. So this is becoming a sort of an increasing contributor to this total pie over here. And then we have some drugs that silently allow all of these essentially to progress to cirrhosis, particularly if they produce chronic liver injury rather than the acute, very severe liver necrosis. In terms of the pattern of injury that we get, we again divide them into hepatocellular, cholestatic, and mixed. For purposes of classification, this is proposed where you take this R value, which is the ALT, which is fold change from upper limit of normal, and you divide it by alkaline phosphatase, fold change from upper limit of normal. And if it's more than 5, that's a textbook classic hepatocellular injury. I don't try to remember all of this. I mean, it's predominantly AST, ALT, it's parenchymal injury. If it's predominantly alkaline phosphatase, it's cholestatic. And if they're both fairly equally elevated from the upper limit of normal, then it's a mixed pattern of injury. So from a practical perspective, when you see the patient in your office, drug-induced liver injury can have a whole spectrum of clinical presentation. You could have a completely asymptomatic patient comes and tells you, I feel fine, I seem to be doing great, but previously their liver enzymes were normal, now their liver enzymes may be elevated. For certain drugs, there's a recommendation to look for elevation of liver enzymes, but routinely, we often don't go chasing liver enzymes every time you start a drug. More commonly and more seriously is when patients develop acute hepatocellular necrosis. If their liver, regardless of whether it's a dose-dependent or an idiosyncratic injury, if they get acute hepatocellular necrosis, they will come in with symptoms. When your liver gets sick, they'll get nausea, vomiting, severe anorexia. They may be jaundiced if it is severe enough. And so this could be mild, moderate, or severe. Severity is dependent by how high the liver enzymes go. So if the liver enzymes are more than 10 times the upper limit of normal, particularly if the bilirubin and the INR, so the liver function is impaired. So you not only have significant liver injury, but the injury is accompanied by loss of function, then that means you got severe hepatocellular necrosis. And by definition, we call it fulminant hepatic failure, when in addition to meeting all these criteria, you actually have altered mental status. So that, of course, means that we're talking about a very, very, very serious condition. Got to get to a transplant center ASAP. Cholestatic liver disease usually presents either asymptomatic, but when symptoms do occur, it's usually in the form of pruritus, jaundice, dark urine, because cholestasis, again, causes conjugated hyperbilirubinemia, and predominantly, as we talked about, increase in alkaline phosphatase. And cholestatic hepatitis, you get features of both. So you get all these up here as well as this, and patients can be asymptomatic or they may have symptoms. And the thing with liver injury is that the symptoms can often be nonspecific. Flu-like symptoms, some vague right upper quadrant discomfort, nausea, vomiting, which are fairly nonspecific. It's until the eyes turn yellow, you may not even think about the liver injury. So you got to have a low threshold of thinking when someone has systemic symptoms for which there isn't an obvious cause, that there might be a liver-related cause. So how do you diagnose that a drug may actually be contributing to this process? So the first thing to think about is the temporal relationship between when a drug is started and when symptoms occur. And after you stop the drug, the speed with which the symptoms improve. So typically, if you start a drug and within a relatively short period of time, weeks, not months, you get symptoms, it's sort of easier to connect the drug to the toxicity. The longer the time frame, and this is the problem with these idiosyncratic reactions, is that particularly the dose-dependent toxicity, typically you start the drug, within 4 to 6 weeks, you'll see the side effect, unless somebody overdoses after years of treatment. But these idiosyncratic reactions, you could be on a drug for 2 years, and then bang, out of the blue, you get this liver injury. So you've got to have a low threshold. I keep repeating that, but it's so important, which is why I keep repeating it. Then all drugs, it's important to know, at least for the 4 or 5 principal drugs that produce acute liver injury and contribute to the burden of drug-related iatrogenic mortality, you should at least know their signature, their classic signature, and I'll walk you through those. So you have to know the temporal relationship. You got to know the signature pattern of injury. It's got to improve with discontinuation. And this morning we talked about re-challenge, but usually we don't go there. Because if somebody had significant liver injury with a drug, most of the time there are alternate agents, alternate approaches you can take. You don't want to go down that road. Because frequently when you re-challenge the patient, the liver injury is much more severe. You've sort of primed the pump. So the next time you re-challenge the patient, the liver explodes. You don't want that. Bad thing. So, and then, of course, you got to rule out alternate. Just because you're thinking it could be drug, it could still be viral hepatitis. It could be still all the other things that produce liver injury. So let's go through a sort of a case scenario which might explain, sort of give you a sense of the signature pattern of some of the common injuries that we see. So this is a 60-year-old male executive, developed some urgency, frequency, and dysuria while on a business trip. He's seen in a local ER and noted to have some prostate tenderness. Urine analysis showed some WBCs. He was started on Augmentin. He took a 10-day course and now is back home. Few weeks go by, and then he comes in to see you and says, last few days, I noticed my urine's turned real dark, and I'm just itching. I don't feel so good. And you notice when you examine him that his eyes look yellow. His liver enzymes are AST is 250, ALT is 350, alkaline phosphatase is 325, bilirubin's up at 6 milligrams, iron are still okay. So what kind of injury does he have? He's got AST, ALT. If you assume the upper limit of normal is 40, his AST, ALT are about 5 times the upper limit of normal. And his alk phos is 325. If the upper limit of normal is about 100, 105, it's about 3 times. So he's got a mixed pattern. And if you remember from this morning, if it's a mixed pattern, almost invariably, think about drug, drug, and drug in this setting. Less common viral or autoimmune disorders. He's obviously got increased bilirubin, so it's something significant. You got to pay attention to it, but it's not horrendous because the INR is still okay. So what to do next? Check for viral serologies, perform liver biopsy, obtain liver ultrasound, or go straight to an ERCP because his alkaline phosphatase is elevated. So I don't know if we are doing the thing. Is it possible to check online? Or we can do a show of hands. Viral serologies. I think that's a good idea. You can never be sure that it isn't a virus. And remember, hepatitis A, we heard about it earlier this morning. We do get sporadic cases of hepatitis A in the United States. The guy travels a lot. Who knows where he ate? It's possible. Liver biopsy, good, no takers. Liver ultrasound, I think it's reasonable. The alkaline phosphatase is elevated. It's a reasonable thing to do. And obviously not an ERCP. Well, he got some labs. His hepatitis A, B, all negative. Hep C is negative. And ANA came back borderline positive. And that frequently happens in a variety of acute liver injury where you get this borderline ANA, which can sometimes cause a lot of diagnostic confusion. So the specificity of these anti-nuclear antibodies is much better when you got high titer, 1 in 640, 1 in thousands. Then it's much more likely to be a true immunologically mediated process. So in this case, as it turns out, mainly because I had to give this talk, that the guy did actually have a liver biopsy. Well, if you're a hepatologist, every liver is a potential target. But because of his ANA and some diagnostic confusion, the guy did end up getting a liver biopsy. And what you see over here is all this yellow stuff. This is bilirubin. So backed up bilirubin, this is cholestasis. A lot of cell death, this intense dark staining cells. This is what apoptosis looks like. This is different than necrosis. Necrosis and apoptosis are 2 different ways cells die. Necrosis, the cell explodes. And in apoptosis, the cell shrinks down and the cytoplasm becomes very deeply condensed. This is very typically seen in drug-induced liver injury rather than just frank necrosis, although all kinds of patterns are seen. And you see a lot of inflammation. So this is a mixed cholestatic, and this is a classic picture of a drug-induced hepatitis. So over here, since he was not taking much else, we made the diagnosis. His viral serologies, part of it is by exclusion. His viral serologies, common things were all negative. And recently, he had taken a drug, Augmentin. So the signature pattern of Augmentin, the point I want to make, is that the liver toxicity may manifest weeks after the patient has stopped taking the medication. So something that sometimes we forget is that the drugs can produce toxicity that if they're not on the drug at the time they get the toxicity, then we say, well, it couldn't be because he stopped it 2 weeks ago. So there's a window of up to 4 weeks that patients can present with Augmentin toxicity. And that's a classic temporal relationship. Yes? The toxicity is more related to the clavulanic acid rather than the amoxicillin component in these patients. But Augmentin is why it's not reported with amoxicillin, this type of toxicity. It's an Augmentin thing, and it's the clavulanic acid that does it. So essentially, we told the patient not to take any medication and come back for follow-up. So when is this cholestasis expected to completely reverse? Days, weeks, months, never? Any takers for days? Weeks? Yeah. And months? Any takers for months? Yeah, actually, augmentin toxicity may take a while. It may actually take a few. So best to warn, if you think somebody had augmentin toxicity, is to tell them, listen, it may take a while. Just don't get bent out of shape. Come back. I'll see you every few weeks and track your liver numbers. So that way they know that everybody's not getting bent out of shape. So augmentin hepatotoxicity, actually, it's relatively uncommon. It's not relatively, it is pretty uncommon. It's about 1.7 out of every 10,000 prescriptions. It occurs 1 to 9 weeks after starting and up to 6 weeks after discontinuation. LFT pattern is typically cholestatic, but mixed patterns can occur. The biopsy shows typical cholestatic hepatitis. One of the things to worry about augmentin toxicity, and which is why you need to follow the patients, is that a subset of these patients, and we can't really predict who, develop something called vanishing bile duct syndrome, which means their intrahepatic small bile ducts essentially undergo apoptosis and disappear, which means there is no way for bile to get out of the liver, and the bile backs up in the liver, and if that happens, the patients may need a liver transplant. So just because you identified the drug and the patient stopped the drug doesn't mean the patient's off the hook. You have to keep following these patients and make sure that things slowly are trending down over time. If they keep getting worse, they may need a biopsy just to look for vanishing bile duct syndrome if they don't turn around. So recovery may take several months, and consider progression to vanishing bile duct syndrome if jaundice persists after 8 to 10 weeks. Majority of patients will get better within the first 4 to 6 weeks, but may take as long as 3 months. So the signature pattern of some of the common causes of drug-induced liver injury. We talked about augmentin. Nitrofurantoin can produce acute or chronic hepatitis. Chronic hepatitis, just like hepatitis C or hepatitis B, it can progress to cirrhosis. INH produces acute hepatitis, and certainly in Asia and many parts of the world is a leading cause of drug-induced death. Bactrim can produce cholestatic hepatitis, again, very frequent cause, particularly in tertiary care hospitals where you have big transplant programs, and Bactrim is used for PCP prophylaxis following transplant. This is a common problem. Macrolides can present with cholestatic hepatitis. We often will see erythromycin or azithromycin-induced cholestatic liver injury. And levaquin can sometimes produce acute hepatitis. And dilantin produces an acute hepatitis with lymphadenopathy and lymphocytosis. It almost looks like they've got some sort of a leukemic process. You get a substantial lymphocytosis and lymphadenopathy, typically, along with elevated liver enzymes in someone taking dilantin. That's textbook dilantin. So these are textbook signatures. So these are sort of the leading causes of drug-induced liver injury in North America. So it's good to sort of be aware. And these are all fairly commonly used drugs. So it's good to know that if these features occur, this could be drug-induced liver injury. This is a second case. This is a 73-year-old lady this is actually a real case that I had. Increasing fatigue, actually the last one was too. But anyway, increasing fatigue, lethargy, nausea, and low-grade fevers. And this was a few years ago, as you can see. She had hyperlipidemia and a history of vesicle prolapse with recurrent urinary tract infections, for which she was on nitrofurantoin, and she was also on simvastatin for her dyslipidemia. She had labs drawn in June and was noted to have moderately elevated liver enzymes. She was not that symptomatic at the time. Viral serologies were negative, and she was told by her primary care physician that this is probably mononucleosis, go home. And she comes back now 4 or 5 weeks later, and she's jaundiced. And she's now referred to us. And at this point, when we see her, her AST is 750, ALT is 990, alk-phos is 116, bilirubin is about 14, INR 1.5, ANA is 1 in 160, mitochondrial antibodies negative, viral serologies are negative. So first of all, what's the nature of her liver injury? This is clearly hepatocellular. It's all AST, ALT. Alk phos is virtually normal. How severe is it? Would you categorize it as mild, moderate, or severe? If we go back, you can see that the bilirubin is 14 and the INR is 1.5. So this is pretty severe. So what could it be? Well, it could be acute viral hepatitis. It could be anything that produces acute hepatitis or acute liver injury with DILI in the differential diagnosis. But while you're sending labs off, one of the first things to do is you don't immediately need simvastatin to stay alive. Stop the simvastatin. You don't need, there are many other choices for nitrofurantoin, that can replace nitrofurantoin. And this is being used more as a prophylactic thing. Stop the nitrofurantoin. And this patient actually got a hepatitis, got a liver biopsy, which shows absolutely textbook hepatitis with what's called interface, where you cannot see this blue all over. So you cannot really distinguish the portal tract from the lobule because of these inflammatory cells all over. And you can see inflammatory cells actually infiltrating the hepatic lobule over here. And that is called piecemeal necrosis and interface hepatitis. This is a textbook picture of what used to be called chronic active hepatitis, if you remember that term from your days in medical school. And this has been, it can occur, it's not specific to drug-induced. You can see it with autoimmune. You can see it with drug-induced liver injury. You can see it with viral hepatitis. But once you exclude viral hepatitis, then, and you're on a drug that is known to produce autoimmune type hepatitis, then that's a textbook picture. So management, when in doubt, stop the drug. Particularly over here, the liver enzymes elevated, rise in conjugated bilirubin and INR. So steroids, what about steroids in this setting? Can you, because if this is a drug-induced inflammatory process, can you cool it down with steroids? So we usually use steroids when there is an autoimmune profile. Now, some of the drugs that produce this acute hepatitis, they actually induce an autoimmune, drug-induced autoimmune hepatitis. And nitrofurantoin is the textbook poster child for a drug that produces an autoimmune-mediated chronic active hepatitis, which can progress to cirrhosis and liver failure. So this patient was started on steroids. So we stopped the drugs. She got treated as though she had autoimmune hepatitis. And she improved with resolution of jaundice over the next 4 or 5 months. Liver enzymes came way down. But then her pruritus returned, and her labs are shown down here. Bilirubin's 4, liver enzymes are now way back down, but now she's got an alkaline phosphatase of 460. So the AST, ALT has all come down. Initially, bilirubin came down from 14 down to 2 or 3. Now it's sort of fluctuating at about 4, and the alk phos has gone back up. So she gets another biopsy, and what we see over here is a progression of the disease more from a hepatitis to this bile duct injury pattern where these, So this is a bile duct over here, and this bile duct is being injured. So essentially, these immunologically mediated drug injuries, which are idiosyncratic, are very serious because initially they start by attacking the liver, but then the pattern can shift over time. And again, this is another drug that can take out your bile ducts, and then eventually you don't have anything left to get bile out of the liver and can lead to cirrhosis. Luckily, she settled down, and we were able to salvage her, but sometimes we're not. So severe nitrofurantoin toxicity occurs anywhere from 0.02 to 0.003%. So it's rare, but it can occur. Just the important thing, therefore, is to be aware of that nitrofurantoin is a major cause of liver toxicity. It can start weeks to years after starting the drug, but it rarely occurs once you've stopped the drug. Now, this is different than Augmentin. Augmentin, you could get toxicity, so you got to know the signature of each drug. So nitrofurantoin toxicity invariably occurs while they're on the drug. LFT pattern is hepatocellular or mixed. Biopsy can show acute or chronic hepatitis. Sometimes you can even see granulomas. It is female predominant, but then most people who get nitrofurantoin for recurrent UTIs are also female, so it's hard to be sure, and often will become associated with a positive anti-nuclear antibody. We use steroids for severe disease, stop the drug, never re-challenge. That's the easy way to kill the patient. So in this setting, other people have done this experiment, and it's really not a good idea. Another drug that produces this type of autoimmune hepatitis type of picture are statins. And so there's always a question about statins, and if you have fatty liver, can you use statins? So the thing to remember with statins is there are two types of liver enzyme abnormalities that we see with statins. One is a minor increase in ALT, so you start with normal or slightly above normal, and it goes to 100, 120, levels off. And it is never associated with increase in bilirubin, INR, patient is asymptomatic. Those rarely progress to significant liver injury or produce liver-related morbidity. There's a second pattern which is quite rare, but given the billions of people on statins, we do see it once in a while. And that's a sudden onset of mixed cholestatic hepatocellular liver injury pattern, which may progress to jaundice, frequently with a positive ANA. Patients get pretty sick, they start throwing up, they act like they've got acute hepatitis. And those are the patients who, if you don't stop the statins, will progress into liver failure and die and may need a liver transplant. So if you see an acute cholestatic or mixed hepatocellular pattern, high AST ALTs, particularly with jaundice, positive ANA, stop the drug immediately. Minor increase in ALT to about 100, 120, no bilirubin, nothing else, asymptomatic. Those patients, you can continue to use the statins. And particularly in the context of fatty liver disease, their number one cause of death in fatty liver disease is cardiovascular. They're much more likely to die of their heart attack than to die of these rare cholestatic statin toxicity. So it is generally recommended, it's actually in the practice guidelines, that you should not hold back on statins in this setting. So statins are safe in the setting of non-alcoholic fatty liver disease. Few words about INH. Those who do actually travel abroad and take care of a lot of people with tuberculosis, this is this is the mainstay of anti-tubercular treatment. 50% of this toxicity occurs within the first 2 or 3 months of starting the drug. The LFT pattern is classically hepatocellular. If you did a biopsy, you would see acute hepatitis. So 10 to 20% of all people who get INH will get some liver enzyme elevation. But only 10 to 20% of this 10 to 20% get severe injury. And of those, again, 10 to 20% actually die from the liver toxicity. And we've had some very unfortunate incidences where we had a nurse in our hospital who got put on INH because she turned positive, he had a positive PPD, developed severe toxicity, and this was not recognized by the hospital employee health, and she ended up getting a transplant. So this can occasionally be seen and be quite severe. So just need to be aware that INH can produce liver toxicity. Worldwide, it's a very important cause of liver injury. And for those who take care of a lot of patients with tuberculosis, there are alternate regimens that are now recommended, and WHO has actual practice guidelines on how to manage tuberculosis in those who have had INH hepatotoxicity. Sulfonamides can also produce toxicity, and frequently it is due to production of reactive metabolites that lead to hepatocellular injury. And so there are both direct electrophilic injury as well as injury through immune responses, because some of these metabolites are bound, they have covalent binding to cellular components that trigger immune responses. And so the immune response to Bactrim and other sulfonamide is actually a mixed from direct toxicity as well as immunologically mediated. And so in Bactrim, HIV-infected subjects are quite susceptible. About 20% has been reported in the literature. And it's also quite common in the transplant population. It starts typically within weeks of starting Bactrim. You see elevation of liver enzymes, and the pattern is either mixed or hepatocellular. If you did a biopsy, you would see just pure cholestasis or cholestatic hepatitis, but it usually resolves, but bile duct injury may last on biopsy for a long time. So for our transplant patients, we always have to keep that in mind so we don't overdiagnose rejection when we see these patients later on. So to some general principles of just I've gone through some different scenarios and different patterns of drug-induced liver injury and talked about at least the common drugs. I mean, the drugs that I've covered, this is essentially 90% of all the drugs that can produce drug-induced liver injury. Theoretically, every drug, if you look at the PDR, every drug can produce it, but that's really the bulk of it. So the general principles in general practice: have a high index of suspicion. Ask yourself the following questions. Is hepatotoxicity present? How severe is it? Particularly if it is severe, what drugs can be implicated? Is it a potential dose-dependent or idiosyncratic? Could it be due to drug-drug interaction? And early discontinuation of offending drugs is the key to survival. So the spectrum of severity, when you put somebody on a drug, the way to predict this, and this is sort of more for drug development, and this is named after Hy Zimmerman, who was sort of a pioneer in the field, is that mild drug injury, which is more than 3 times the upper limit of normal, frequently occurs, but symptomatic disease, if you know what the prevalence of mild liver injury is, 10% of that is typically symptomatic, and 10% of that will be acute liver failure. So if you're doing drug trials and you're involved in congestive heart failure study and you have 5,000 patients and you get 5 patients out of 5,000, you can do a projection that if this was a drug used by 100,000 patients, what would be the number of people who would have symptomatic disease or acute liver failure. And severe drug injury is, again, just to emphasize, because this will kill the patient unless you recognize, stop the drug, and refer the patient to a transplant center, is ALT more than 10 times the upper limit of normal, rise in conjugated bilirubin, increased INR, and mental status changes. Causality assessment, there's a whole spectrum from definite all the way to excluded, but it's a moving target, because there is no one blood test which says, oh, this drug clearly is the cause of your liver injury. So you have to exclude all the other types of things that may be causing liver injury. And it's, again, based on the classic signature pattern and the temporal course, we make a decision. There are tools that are available. These are probably not that relevant in clinical practice, other than they're also pretty dated at this point in time, but that look at the temporal, all of the things that we talked about to make an assessment. And there's a score, and you can come up with a score and identify whether it's unlikely or highly probable that a given drug was the cause of the liver toxicity in a given patient. There are newer scales that have been developed, and even this is 20 years, 15, 18 years old now. And once again, you develop a scoring system. This is more for epidemiology and for the FDA to keep track of causality, and when they make assessment, whether they're going to put a black box warning on these drugs. For regular clinical practice, these are much less important. What you have to remember is there injury? Is there significant injury? What drugs could be possible? Stop those drugs, look for alternate agents, and look for alternate causes. If you don't have an alternate cause and things get better after you stop the drug, most likely it was the drug that caused it. And again, these are looking at essentially the distribution and using some of these panels. Essentially you get this distribution of from definite to excluding when people get acute liver injury. I'm not sure, again, that in routine clinical practice that these really makes a big difference. These are, again, tools that are used for public health purposes. So most of these, the faster after you start a drug that there's toxicity, it's easier to connect the drug to the toxicity. And that's the bottom line. I think that you have to remember although all these different, the chronic drug injury and the RUCAMs, essentially, they have different performance metrics that we don't necessarily need to get into in more detail. Finally, this is the FDA website for all drug-induced liver injury. It's strongly recommended that if you see a patient that you strongly suspect had drug-induced liver injury, take a couple of minutes and put it in there, because it really helps, particularly with these rare toxicities. It really helps the country as a whole and our communities as a whole, so that we can gather, see if their number of people have these type of toxicities, then the FDA can make some decisions on when to put a warning out there. So I will finish by saying what I've already said before. Know the side effect profile and toxicity signature of every drug you use. This goes beyond drug-induced liver injury. This is sort of a good medicine practice anyways. Have a high index of suspicion or a low threshold for thinking about drug-induced liver injury. Don't forget other drugs or causes of liver dysfunction that you must also look for. If other causes are absent and the signature fits, it's highly likely that you have iatrogenic toxicity. Assess the severity by looking at liver function and mental status very early. Stop the offending drug as soon as you think it could be drug-induced injury. And for severe toxicity, find the nearest transplant program and send the patient there. Thank you. Yes? It's the clavulanic acid.
What about the pediatric population when you use several rounds of antibiotics for irritation and all things there? Do you see this?
It's very rarely reported in the pediatric population. I'm not actually aware of any pediatric. That doesn't mean it doesn't exist, but I'm an adult hepatologist, so but to my knowledge, this is predominantly described in adults. Other questions? Yes.
Patients that have moderate fatty liver and diabetes, a lot of the diabetic medications have warnings against liver injury. If they have low-grade liver enzymes, is it still safe to use those?
Yes, actually, yes, for the most part. The idea that if you have, so there are two types of this drug, there's dose-dependent injury and there's idiosyncratic injury. There's absolutely no, for most of the severe toxicities, those are idiosyncratic injury, like metformin and things like that. There's absolutely no data that if you have underlying fatty liver, your risk of idiosyncratic liver injury is increased. And so many of our patients with fatty liver disease are on metformin for their diabetes control, as well as some of the new SGLT inhibitors and so on and so forth. So it's not an issue. The bigger issue, we didn't talk about fatty liver disease, but it's a really big public health problem. It's very common. It's very underdiagnosed and underreported in the diabetes clinics. If you went to a primary care in your own offices and took all your type 2 diabetics, and you actually did MRI to quantify liver fat and MR elastography to look for fibrosis. Those are some of the sort of new techniques that are being developed. 50 to 60% of your type 2 diabetic population do not just have fat, but they actually have steatohepatitis with some degree of fibrosis. There's a paper that is in press right now from UCSD where they did just that. They looked at 250 people in a primary care doctor's office who were diabetic and scanned them. They found one incidental hepatocellular carcinoma, and they found about 60% of those type 2 diabetics actually had NASH with fibrosis. So it's underdiagnosed, underreported. It does exist. That should not stop you from treating their diabetes and cardiovascular disease, because quantitatively that's still the #1 cause of death. But I think we need to have much more awareness, and it could be a good topic for future meetings to talk about evolving therapies, because we are getting close to getting approved drugs for NASH.
Do you see vitamin E helpful at all in that condition?
I'm biased because I was the author of the Pivens trial. So, yes, actually, vitamin E is significantly, the largest amount of data exists for vitamin E in non-diabetic patients with NASH. We didn't study it in diabetic patients because when we started that first trial, there was, a lot of concern that, diabetic patients get so many drugs, which also could help NASH, and then it would confound the analysis of the trial. So we wanted to be almost like a proof of concept trial. So we took that out. But more recently, we have looked at diabetic patients. This has not been fully published. This has just been presented at the last liver meeting. Vitamin E also works in diabetic patients with NASH and actually works even better in diabetic patients with NASH. Interesting thing is that there are now some pharmacogenomic biomarkers that may be helpful in identifying therapeutic response to vitamin E. So haptoglobin is the principal antioxidant we have in our body. And so there are two genotypes of haptoglobin, 1 and 2. So you could be 1-1, 1-2, or 2-2. 2 genotype has poor antioxidant properties. So those people who have genotype 2, they have greater susceptibility to oxidant stress. And NASH injury is largely mediated through oxidant stress. And we've, again, not fully published. We just presented this at our annual meeting, that as you go from 1-1 to 1-2 to 2-2, there's a progressive increase in histologic response to vitamin E. And you can stay within 400 to 800 units. The meta-analysis that was published about 10 years ago about vitamin E toxicity has been largely debunked, just like the pioglitazone and the bladder cancer story. But even if you're still uncomfortable with 800 units, the histologic response rates are similar with 400 units. So vitamin E certainly, but there are newer drugs like obeticholic acid and others. There are 2 drugs that are going into pivotal trials right now for NASH. Yes, sir.
Given that statins are on the list for common drugs that cause arrhythmias, why has the recommendation to screen liver function tests for patients being placed on them been relaxed?
Well, part of it is because it is the significant toxicity is extremely rare. And what has happened from a public health perspective is that too many primary care physicians were stopping the statins because of a minor change in liver. Remember, there are 2 patterns of liver enzyme abnormality. One has no clinical consequence for the patient. The other has a huge clinical consequence. The 99.99% of the time, it's the non-clinically relevant ALT elevation. And the risk of cardiovascular disease is still the leading cause of death. So in terms of relative risks, the risk of dying from cardiovascular disease is way higher than the risk of getting the rare hepatocellular toxicity. And because it's idiosyncratic, just checking a liver enzyme at 6 weeks doesn't mean that, if it's normal, doesn't mean that 3 months from now or 5 months from now, you won't get that rare toxicity because it's idiosyncratic. So those are sort of the reasons why people have sort of backed off being uber, oh, you got to check a liver enzyme. If there's any elevation, you got to stop the drug.